This is my topic, how I choose my stents, and here's my disclosures. And really, there's no doubt that our OG is this gentleman, and we really owe him a lot of thanks for his wisdom and foresight decades ago that has now helped literally millions of folks across the world. And it all started with the venous wall stent that got grandfathered in 2020. And we're all familiar with this. I don't need to belabor that, but there's no doubt that we've been able to help a lot of complicated folks over the years with Dr. Raju Naglin's kind of wisdom and whatnot that led to therapies such as this. So what that eventually led to was the FDA trials, and ultimately here's the approved FDA stents that are available. Been fortunate enough to use all of them, but the Duo so far. Too bad Vici went off the market. I really thought that closed cell stent worked well, but we're all aware of the complications that some folks had with it migrating northbound that led to it being removed from the market. So what do we have? Well, likely the market leader right now would be Abre based on number of cases throughout the U.S. We know that this device works quite well. It comes to up to 10 to 20 in diameter, lengths of 40 to 150, good visibility, et cetera. And this is one of our patients who came in, a 58-year-old gentleman, had a history of left leg varicose vein surgery decades ago. And when he came in to see me, he had C4B disease. His left leg, just like Paul and Jose had mentioned, was uniformly edematous from the malleolar area all the way up to the thigh, indicating the underlying iliac vein stenosis. We had already maximized medical and compression therapy with the calf muscle pump. So what we decided to do was obtain a CTV, showed this common femoral vein occlusion. The femoral vein and the profunda were patent. What I actually used was an RF wire to cross this from Bayless. I was able to eventually cross that, place our Abre stent here, and this gentleman, this was several years ago, and he's done quite well from this intervention. And here he was in post-op. And what it really kind of taught us years ago was that there's so many folks afflicted with venous disease, and CTOs can be difficult, but they can be treated. We follow, as I think Paul just alluded to, the SVS and AVS guidelines, and we're pretty conservative and only treat C4B, 5, and 6, and rarely a C3 patient. And with that, as Paul also taught us, IVC is really crucial to this. So other available options out there are the Zilvervena. We were lucky to be in the Vivo trial years ago. It comes in 10 to 16 millimeter diameters and 6 to 140 lengths. It's been available in Europe for quite some time and has excellent results and is a very efficacious device. This was our first patient. Jamie came in. She was post-thrombotic. I met her when she actually had an iliofemoral DVT during pregnancy. She came back. She had C4A changes. Once she got through her pregnancy, about 8 or 9 months later, we decided to offer her an intervention. At that time, I put a 1660 Zilvervena in. Today, I definitely put a longer one in, but that was probably 8 or 9 years ago when we treated her, and she did well post-procedural as well. Of note, I think both Abre and the Zilvervena have data looking at their, like a subgroup analysis, looking at the stent across the inguinal ligament, and suffice it to say that the Zilvervena is very efficacious, not only in the iliac segment, but also down in the common femoral area as well. Another one that's very prominent is the Venovo, really the first one that became approved in 2019. Also comes in diameters from 10 up to 120 and lengths 40 to 160. And it's really the longest one out there and has excellent patency at 3 years from the industry-sponsored trials. Another one of our patients came in with C4B disease. Had combined disease. I offered superficial intervention first. We ablated it. I waited 6 weeks after the intervention. Really no improvement in the venous claudication. So at that point, we offered a Venovo stent. And here you can see we put a 12180, or it's 1280, excuse me. Again, based on some data I'm going to show you here in a minute, probably put a little bit longer stent in today and kind of take it around that pelvic brim. What I like about all these stents is, you know, the thumb wheel for the Venovo and Abre, and then the pin and pull for the Zilvervena. You're able to pretty much put it spot on the iliocaval confluence, provided that you're utilizing IVC guidance. We also know that the duo from Philips is now here, and Mahmoud did an excellent job with that trial, and again, showing excellent patency at 12 months. And what's nice about this device is it's very flexible distal, but very strong, and has crush resistance proximally. So at the end of the day, though, when it comes to placement, what you don't want is a stent that's too short, because if it doesn't lock into the bend, it could migrate. You don't want one that's too wide, because if it's too wide, then not only you can end up with back pain in the short term, but perhaps this effect as well, where if you oversize it, you're going to have axial tension, and you could have adjacent vein narrowing. So it's really important that it's not so much the stent that you're going to pick, but definitely you want to size it with the diameter and length appropriately. And I don't need to belabor this trial. We talked about it yesterday, but Paul kind of led the way with IVC guided intervention and stenting. And really with that, when we bring folks in, we give them 500 cc's, sometimes a liter in the pre-op hold area before we take them back. I think hydration's important. We talked about that yesterday. And again, you don't want to undersize your stent. You don't want to oversize it. But ultimately, you also want the stent normal to normal. And not only did Dr. Raju and the folks from the South, but others, as I'll show you here, really showed the benefits of IVC. We know that venography can fail to identify the existence of a lesion, but not only that, but it's very important. IVC can help you to locate the iliocaval confluence and also correlate with the appropriate distal landing zone as well. So not only did the folks in the South, but also up in Pittsburgh show the benefits of IVC guided intervention. It directly correlates into patency with your iliofemoral stenting. And as I mentioned earlier, though, it's important that you can't undersize, and you also got to put the appropriate length, because if you don't use a long enough stent, if you don't lock it into the beyond the pelvic brim, you can have situations such as this. And this is one of our cases locally. This patient had an intervention. It was not identified until 6 months later that this 1460 stent had migrated up to the left PA. I had it here with a snare, but it was 6 months out. It was not coming out. Obviously, I didn't want to cause a perforation, so ultimately this gentleman had to go for a open heart. So why else, is it important to use IVC for stenting and identification of the iliocaval confluence as well? Here's a case that came in about 2 or 3 years ago. One of my partners did a very good job at that time, went ahead and did a single session thrombectomy, was able to ultimately place this stent and treated the left side appropriately. However, I think those of us who do a lot of this can see that there's a suggestion that perhaps it's a little bit too high. Well, then she came back about 1.5 years later, and at this time I did her under local and sedation. Subsequently, I transitioned her to general. You can see here she's moving around, she's anxious, etc. Well, now she's got a right-sided iliofemoral DVT because of this stent had landed too high. Just a unfortunately terrible landing of the stent. Considered this, given her age, an open surgical removal. This is a good article from Dr. Glavitsky talking about removing this open. Ultimately, though, despite the poor landing of the original stent and given the overall situation, we went ahead and did a thrombectomy and then decided to put another stent. And of course, I worry about this in the long run. Taisha's 32 years old, and now she's got bilateral iliocaval stents, and it's really concerning. So as far as our individual experience, this was a retrospective study that we published a couple years ago, where we broke down our patients into 100 or longer than 100, and really in all 3 cohorts there was no difference, suggesting that it's efficacious to put a longer stent in. So if you need a 120 or 140, in our hands a 16-140 is the most common stent we place. And then also we followed this up at the AVF this past year. We looked at our midterm results. We had 76 folks, again, all 3 patient categories. And again, there was no difference in stents, whether they're 100 or greater than 100 in length. So ultimately, this is probably the most important slide if you're looking at the various stents. Kind of some final thoughts. They're all nitinol because nitinol works. It's flexible. All of them have minimal fractures. They all help in their industry-sponsored trials with the quality of life and the VCSS scores. Aubrey and Venovo are the biggest. Venovo is the longest. It has flared ends, perhaps mitigating against migration. And Zilver perhaps is the most flexible cross-lingual ligament. But ultimately, there's no head-to-head. And as Paul alluded to, you got to individualize each patient based on their scenario as well as their IVC and decide which stent's best for you. So in conclusion, you follow the guidelines, especially for nivels. If the IVC is not conclusive, then let it go. And you definitely want to stent normal to minimize migrations. And you need the right stent, the right diameter, and the right length. So thanks so much.